Welcome everyone. I'm really happy to have you all here to celebrate Scleroderma Australia's 20th anniversary. Yes, absolutely. So my name's Amanda Laurie-Jones. I'm the current chair of the board for Scleroderma Australia, and I'd like to acknowledge the traditional custodians on the land on which we meet today, the people of the Gadigal on the Eora Nation. So it's wonderful to have so many members of our scleroderma community here today, people with scleroderma, our partners, our family, our friends, and our board members. So quickly today, I wanted to run through the agenda. So thank you all for coming today. We'll have a panel discussion this morning. So we're going to be talking a little bit about the evolution of care for scleroderma. So we'll have the original committee member, current committee members, and some long-term ones as well. We're going to be launching our scleroderma awareness video. We'll have a morning tea break. And then we've got another panel discussion with the amazing Professor Mandy Nickpour. And then we'll break for lunch. So I'm going to get straight into this before I talk about the afternoon. We'll leave the afternoon for later. So a little bit about Scleroderma Australia and the history. So it is recorded that we were founded in 2005, and we have operated as a national organisation ever since. So our state associations brought us together, so Scleroderma Queensland, Scleroderma New South Wales and Scleroderma Victoria. I'd like to welcome our board here today. So this is our current board. So our board members, I'd be happy if you pop your hand up to make yourselves known as we go through this. So we have Tara Hanneveld, who is my deputy chair. Thank you, Tara. Ian Pizzi, also known as the Money Man, so he's our treasurer. I always love to call him the Money Man. I'd like to welcome Kate Legg, who's our secretary, so thank you, Kate. Marilyn Singer, so Marilyn is on the board, but she's also the president of Scleroderma New South Wales. Unfortunately, Louise Inglese couldn't make it with us today. She's actually boarding a flight over to Europe. Dr. Stephanie Fraid. So where's Stephanie? There you are. Thank you, Steph. Kim Hindle. Thank you. Unfortunately, same with Greta. Greta's unable to make it today, but she sends our regards. We've got Justine Jackson. And Liz Yunkin. There we go. So I just want to say that your leadership, commitment and passion is amazing, and thank you for everything that you do. Now I'd like to start a little bit with our first Australian committee. So I'd like to acknowledge that today's not just an anniversary, it's a celebration of a story. A story built on resilience, collaboration and a shared drive to make a difference. Our story began in November 2004 when leaders from New South Wales, Victoria and Queensland, supported by Actelion, came together in Canberra for the very first time. What could we achieve if we united together? That meeting set in motion something extraordinary. By July 2005, I might stand back a bit, sorry. Scleroderma Australia was formally incorporated, and by January 2006 is when we received our deductible gift registration. So honouring our founding members, within the photo here, we have Jan Elliott from Victoria, who's also with us in the room today, so welcome Jan. Fiona Flanagan, Glenda McHugh, Sue Barwick, I think is how you pronounce it, and then we've got Colin Breeze and Dawn Breeze within there as well. How do we scroll that down? Oh. Yep, that's what we need, thank you. Missed the last name, sorry. So we've got Mary Sedatrius, Shelley Phillips O'Brien, and Jan McGregor. So this group was supported by the dedicated early leaders being volunteers, and they're more important than just names. They're the heart and soul of the New Beginnings. So I'd also like to acknowledge some of the previous presidents of Scleroderma Australia before me. So Jan, welcome today, as we said, previous president, our first. Robin Sims, who led from 2010 to 2015. Jean Swinstead was elected our third president in 2015, and then I took over in 2019. So we all played an essential role in shaping who we are today. Let's move on to 20 achievements in 20 years of Scleroderma Australia. It's really great that the early years, so building our national identity, so there was the establishment of the national organisation, formal incorporation and recognition between 2000 and 2005. The biggest launch, I think, for Scleroderma Australia was 2006 in May, so the national awareness launch where Actelion funded the exhibition stand at the Australian Rheumatology Association conference. So, and welcome Tracy from the ARA. And then of course in 2006 we launched our national website as well. Then we sort of grew into a national community, which I think was great. So by 2013 to 18, we expanded in regards to our Facebook page. We established the medical and scientific board. We created structure for national research. We had the early funding of quite a significant amount of money to invest in research, which was pretty amazing. And our community in our Facebook grew from 300 members in 2013 to 1,400 by 2018, and now we're at 3,200, so that's pretty amazing. Our awareness campaign, so we've come a bit of a long way on a journey. So as we all know, June 29 is World Scleroderma Day. So that one we've been doing for the past 20 years. And then we've created Snuggle Up for Scleroderma. So Snuggle Up for Scleroderma is where people get into their jammies, their warm clothes, wear their favourite hats and gloves, etc. during winter to try and stay warm. In 2024, we expanded our awareness days to create our own National Sunflower Day. So this is unique to Australia. We created this day because World Scleroderma Day was really difficult for people to go out in the winter months. So in order to have something in kind of autumn, kind of just on the edge of summer, but the warmer weather so that people could actually go out and enjoy National Sunflower Day. So with National Sunflower Day, is March 23, so that's only 2 days away. So pretty exciting in regards to how this started. So we started lighting up buildings across the country. So the first year we lit up about 110 buildings, then it's grown to like 130, and year on year we keep growing. And this year, as in Monday, we're going to be having 150 landmarks across Australia lit up in yellow. So it's pretty exciting. I just wanted to take a minute to share our quick little video from last year around our Shining Up buildings. So my ask today is have a look on social media on Monday or the days leading up. If you're out and about and you see the places lit up in yellow, go out with a yellow t-shirt, go and take some selfies and get involved. That'd be great. Just a little bit of history around our logos. So basically it started with the sunflower and evolved over the years. So the first one was, of course, in 2006. Then we grew to the second one in 2014. And the last one is a little bit more recent. So as you can see, Scleroderma Australia adopted the symbolic sunflower so that people with scleroderma can turn towards the warmth. Partnerships and advocacy, I think this is a really good highlight in recent years of our journey. So lots of collaboration through the SPIN International Partnership, advocacy achievements including submissions into the Medicare listing for NT Pro BNP. I can't believe I said that without getting it wrong. Representation in national policy spaces, so the NDIS review submission, other health strategy submissions that we've done, and we've developed and strengthened our partnerships in recent years as well. Governance transformation. So in 2023, we evolved from an incorporated association into a company limited by guarantee, just to strengthen our governance across the country. Establishment and expression of funding in expansion around our ASIG nurses, telehealth pathways nurse program, so that was a really significant one that we've got and has been highly successful. In the last 12 months alone, the telehealth pathways nurse has seen over 120 patients with scleroderma across the country, so that one's been really invaluable. Major investment in future research as well, so supporting ASIG in regards to a fellowship and the University of Sydney PhD. Last but not very least here, I think this is really significant. 2 decades of continuous volunteer leadership. Every single one of us on the board and our state committees are 100% volunteers. We do this out of love and passion. And I think this quote is really significant. So I'm going to pause here for a second and actually ask Ian Pizzi and Marilyn Singer to please come up, because we would like to award you with a certificate of appreciation for your volunteer over the many years. I'm glad I held it from you. Yep, just sit down, yeah. You're most welcome. So from a meeting room in Canberra in 2004 to this room in 2006, hosting our very first national conference, made possible, of course, with the support from Boehringer Ingelheim. So again, thank you, Boehringer. I'm not quite sure where you all are in the... Oh, they're perfect, thank you. Really appreciate that you could make this happen for us today. Now I'd like to also... going to hear from the original committee members, a current committee member, board member, and one of our newest board members. So if you'd like to come up, that would be great. Yep. Janelle, where's Janelle? Oh, yeah, perfect. Great, Jan. Take a seat. Perfect. Yep. Musical chairs. No. You wing it, Jan, don't worry.
I'll get my bit of paper. No, it's many papers.
All right, so now that we're all together here, I'd like to reflect again a little bit more of the determined volunteers that I've got sitting here next to me. So absolutely delighted to welcome our panellists. So Jan, so you're our foundational leader and early pioneer is what I'm calling you.
That's okay.
So Joanne grew up in Victoria, where a strong sense of community shaped her life. She began her career as a teacher of hearing impaired children, and then with her husband Hedley, Jan later restored the historic Emu Bottom homestead in Sunbury. So Jan joined Scleroderma Victoria in early on, and then became president. I can't remember what year.
Yes, I joined in 2005. No, I forget it.
It's okay. It's all good. No worries. Thank you.
No, I started. No, that's what I finished. I'm sorry.
All good. All good. It was a long time ago. It was a long time ago.
Yes, 2000. The year 2000.
Absolutely. All right. Perfect. Thank you. I'd also like to introduce Ian. Ian, as I said, is our treasurer for Scleroderma Australia, and he came along in the early years as well. So he came onto Scleroderma Australia about 2008, and so Ian's a certified accountant and has been our money man for a very long time. So thank you, Ian. And then Liz. Liz is our newest board member. Liz is from the ACT, and so we've got an array from, I won't say old, but original Jan, so original up into our newest and brand new. I just need you to scroll. Sorry. I'm going to start with a couple of questions to our panel members here.
Just a quick swap, it's not working as well.
Oh,
There you go. Thank you. And there's another one. There you go.
yeah. I'm just waiting for you to scroll the page.
There you go.
Scroll the page. How do I scroll?
Technology.
See? I'll go back. This is annoying. Oh, I can't see my questions in here. That's okay. I've got them now. Without my glasses. All right. So let's see if I can read this without my glasses. All right. So how it all began. Jan, just wanted to start with you if we can. What was the moment that actually brought the need to establish Scleroderma Australia?
Well, it really started long before that, and I think is that coming across? Can you hear that? Right. I think as I look around this room today, I know that we've all taken different paths to arrive here, and how we came to learn about scleroderma. For our family, our path was when our daughter Jolie became ill when she was about 12, and so our path with scleroderma started, and then it continued until the day after Jolie's 22nd birthday, when she died from the effects of scleroderma, and that was in 1991. And we then really knew how dreadful this disease could be. Can I go on with this?
Absolutely, Jan.
I didn't have anything to do with scleroderma for many years after that, and it was only when Scleroderma Victoria approached us to have a luncheon at our venue, which was Emu Bottom, to celebrate their 21st wedding. Not wedding, no. We did weddings, but this is 21st birthday. And in being part of them there, I could see how difficult it was for them, all the work they had to do to keep this organisation going, and as well as they were suffering with disease as well. So I put up my hand and said, well, look, if there's anything I can do, please let me know. So I then became involved in Scleroderma Victoria, and then it seemed no time at all, suddenly I was president of Scleroderma Victoria. I think they saw me coming. And just at this point in time, I'd really like to acknowledge all the work of those early members those pioneers of that time, with little resources, getting these organisations going, having meetings, trying to get the word out there about scleroderma when it was just a very difficult word anyway. Nobody knew anything about it. And I know in Victoria, I think we started about 1979, so that's very early on. And then I think it was probably similar in other states. It was, I was president for quite a while then, and it wasn't, and I don't remember us being very interacting a lot with other states at that time. I think we all knew that we needed to have a national organisation, but how to do that? And I can remember early in 2004 that I had a meeting with, I think it was the CEO of motor neuron disease, because I had heard that they were a national organisation, so I went along to have a chat about that. Well, he was not very encouraging. He said, well, look, it takes a lot of money and it's so time-consuming, and I don't know what his role was there, because he actually said to me, I can't see the point of it. So I thought, well, that's not much use, but there was one thing he brought up, and that was that the motor neuron disease organisation had adopted a flower emblem, and I can't remember if it was the cornflower or if it was the carnation, but it just triggered with me, you know, this horrible disease which was scleroderma. Why not have a beautiful flower to prevent it? And into mind came the sunflower, this happy yellow flower, which by its nature turned towards the sun for warmth. And that rang a bell to me with people with scleroderma. It was uplifting, and it covered up or dispelled the idea of the greyness of the word scleroderma. So in Victoria, we went ahead with that, and we had a design made up, and we started using it. And it was something we were sort of proud to show to people, because they could relate to it. I've got so many bits of paper here.
We might jump to another panellist first for a question, and we'll come back to you, Jan. But thank you for that. That's wonderful. Ian, I want to kind of throw to you, if that's okay. So longevity and stewardship. You've been on the board since 2008. So from your perspective, what's been the most significant turning point in Scleroderma Australia's evolution?
Okay, first of all, I'd just say to Jan, you were my first president for Australia and for Victoria. Yes. So
I remember that all very well.
As far as being the treasurer, no one else wanted to do it, so I think I walked into it, as they say.
We grabbed Ian. We grabbed him.
We're not letting him go.
My journey with scleroderma is my daughter got diagnosed when she was 9, and very young. I've got 2 daughters. The oldest is 5'5", and the other daughter is 6'3". So I think the methotrexate steroids she took when she was about 11 has impacted her life, but she's alive and she's 29 in May. So works for JLL in property, has done a commerce degree, so you know, as we all know, it affects everyone differently, so it's always positive stuff. So my biggest positive to come out of being on the board is the impact of social media, and I think like Jan was saying before that you didn't know where to go to, but with social media, Facebook, we have online forums which has caused a remarkable transformation in visibility for Scleroderma Australia and all the sclerodermas. Each state has its own website, Facebook page. We now have national online support groups which raise our profiles. Ensures that if you do get diagnosed with scleroderma, you can research it and hopefully meet up with someone and support group leaders and support groups to try and get the positives out of it. I remember when my wife looked at, my daughter had tight calves, and she Googled that, and it was scleroderma, and she said, well, that's not it, she hasn't got that. So that just shows you the wide range of scleroderma. So as you mentioned in your review, Amanda, with social media, you have fundraising campaigns, and it's all about money for me, and whatever money we can raise, we can then research and spend on research. So you got the World Scleroderma Day, you said Snuggle Up for Scleroderma. A pivotal moment in our journey was the establishment of ASIC. I think, nationally, the hospitals or the professionals got together and worked out where they were going to research properly and what was the best way to research and spend money. So I know Australia and the States have all put money into ASIC to help them fund the research over the last 4 years, and so mainly since COVID has finished, Scleroderma Australia has funded $520,000 in various medical research projects. And which it's a team effort, and over the last 3 years we've actually started supporting scleroderma nurses at 7 Australian hospitals. So I think that's a really big one as well, that the rheumatologists and the nurses and the people running the hospitals know that we're funding salaries, so it gives us a bit of a profile. I just think we need to have ambassadors, because from a social media or influencers point of view, you need public figures to promote it. Fundraising has also been made easier because you've got PayPal, where if people want to make a donation, they get a tax receipt straight away and they know it's coming to us as the charity. You've also got My Cause, Everyday Hero. There's a lot of people who do their own individual fundraising activities, which has been great. That's about it. Unless there's another...
See, this is why we call him the money man.
Okay.
Absolutely. Thank you, Ian. Absolutely. Liz, I just want to now move to kind of the role of the community. You're a newest board member, one of, and just kind of wanted to kind of ask you, how have support groups and online communities changed the way people with scleroderma find connection, information and hope?
Yeah, thank you. So I run the support group in Canberra, which, although it's the national capital, is also considered a regional area. And so we've got people from Canberra, but we also have members from regional New South Wales. What I've found is that we know scleroderma is rare, but unlike some other rare conditions, you don't hear about scleroderma in everyday conversations unless you have it or you know someone who has it. And so people can be diagnosed at any age and never have heard of it, never know anyone else who's got it, and just have no clue what's going to happen to them. And often they think it's a death sentence and they should start preparing their will or slitting their wrists. I think the support groups provide a really important role in showing people the breadth of the ways that scleroderma can affect you, but also the life that you can have with scleroderma. It's not a death sentence necessarily. There are ways to manage it, and you can have a really productive and happy life despite having scleroderma. It's also showing the range of different ways that it can affect people. So some people in our support group, I've got the traditional contracted hands, but I think there's only about 2 or 3 people in my whole support group who have that. Other people have a range of other symptoms. So I think it's really important for people to get a sense of what's normal in scleroderma when you're not normal. So we can't compare ourselves with our friends and family necessarily. So when you do get tight calves, you can come to a support group and say, has anyone else got this? I've never heard of that going with scleroderma, and then you can find out what the links are. So I think the other thing is, as Ian said, COVID changed a lot of things, and that made online support groups much more accessible to people, which means that people in regional and remote Australia now also have access. So there's an online national support group that Tara runs. Thank you, Tara. And it also allows us to have very narrowly focused support groups, so not just regionally focused, but we've got the men's support group, which is run online. And that's a brilliant opportunity for blokes to get together and talk about it, because it's so often a women's complaint, as they say. And I suspect that we'll probably see more of those focused support groups in the future.
Thank you, Liz. That's great. And again, acknowledgement to the Lung Foundation for helping set up the men's support group online. So thank you for that. So research, advocacy and impact. So in your view, and this is open to anyone who would like to answer, how has research and advocacy transformed the experience of people with scleroderma living in Australia? Anyone?
I'll throw something in to start. I think what's really good is that we're now hearing the patient voice in research. So we're building in what patients think is important to them and being able to feed that to the researchers. And we're also doing research beyond just treatment options. Of course, treatment's incredibly important, but there's a fantastic research project that's being funded by Scleroderma New South Wales and Scleroderma Australia, and I think Scleroderma Victoria and Queensland as well, where there's some big data work going on to try and identify where the scleroderma cases are around the country, whether there are clusters in different parts of the world, in parts of Australia, and therefore where the services need to get to make sure that the people in regional areas have access.
Thank you, Liz. The other question again, what do each of you hope that the next decade of scleroderma looks like? What should we be striving for?
Maybe I can just add one thing, which is not really long that, but when we were sitting there, I said to my son Julian, who's with us today, as I looked around, it was quite amazing to me to see so many young people here. When I was involved with scleroderma in Victoria and that, if we'd have a meeting, it was mainly old people there. So I think you'd have to say something's working, and people are being diagnosed much younger, and through that being able to being treated for scleroderma much younger and have a much better outcome.
Thank you, Jan. I agree.
Yes.
Thank you. Any other final comments about looking ahead?
I just think with social media that that's where we have to go. And if you're doing all the online chats, that helps everyone become a bit more comfortable. And I know there's more and more people meeting face to face, and I think this is our second meeting ever. The last one was 2008, so it's great to be all together and catch up and talk about our issues and hopefully get raised and then start new friendships and networking. And I just think also probably ambassadors or influencers. Like in Victoria, we've got a footballer who's got MND, and the amount of money he's raised has been unbelievable. Neil Danaher. So that's what my take is. Social media has helped so much, and the more funds we raise, the more we research. So from everyone here, the money that comes in, we allocate it based on what ASIC tell us to or guide us by. So and all the fundraising we can do is appreciated.
Yeah, fantastic. Thank you. Any final comments, Liz?
I just want to paint a nice picture of what I'd like to see in the future, which is wraparound services for scleroderma patients with specialists, allied health practitioners and nurses all working together to make sure people are diagnosed quickly, but importantly that they're also, when they're diagnosed, they're pointed to support groups and they're pointed to all the other services that are available to them so they know where to go and what to do and how to keep living.
Thank you. Jan, one last comment?
Well, one thought that came to mind, it was like with the person Ian's mentioned, that... Is that working? Is right? I didn't hold it up far enough. It's about philanthropy. But basically, the more people they can find in important places that have had some connection with, through their families, that with scleroderma, it's a great, as in that case, Ian, is a great impetus to get money to be donated into Scleroderma organisation or Scleroderma Australia.
Thank you, Jan. So thank you all so much for sharing your reflections, your wisdom and your stories. We really appreciate it. I'm not sure how we're going for time. Okay, great. We will finish up here and thank you, Jan. We've got a little bit of a gift for you as a speaker, so thank you very much. Just want to... Yep, there you go.
Oh, thank you very much.
Perfect. Thank you everyone on the panel. We will now move to our next piece where I'd like to invite Tara Hannavald and Dr. Emma Burrows up, so thank you. Yep.
So good morning, everybody, and thank you for being here. This is very exciting. So as I've been introduced, I'm Tara. I'm the Deputy Chair of Scleroderma Australia and the President of Scleroderma Queensland. And today's our presentation is about visibility, voice, change. It's about making sure that people who shape our health system finally see that scleroderma awareness is important, that we live honestly, urgently and in full colour. We are launching the Scleroderma Awareness Campaign in partnership with Trial Screen and the Melbourne Playback Theatre Company, two organisations whose expertise and care make it possible to tell our stories and powerfully, safely. So why is this campaign important and why now?
Thank you, Tara. My name's Emma, as I've been introduced, and I'm from Trial Screen. We met Scleroderma Australia through our work in clinical trials, and our mission is to connect people with research and, importantly, to shift the system to prioritise people and those who need it the most. So we were really honoured to work on this project together. Our missions are very aligned. So I just wanted to say that I was one of those people that did not know about scleroderma. Liz mentioned the invisibility of scleroderma, and this is exactly what this campaign aimed to rectify. One of the things I didn't know, of course I didn't know about scleroderma, but the more I engage with your wonderful community, the more I realise how many more people need to know about scleroderma, but importantly those people that make decisions in the health system, those people who make decisions in our highest powers in Canberra. So this campaign was very much designed to be in their minds and in front of them. So I just wanted to talk a little bit about our goal as well, and it's to not just affect health and policy makers, but importantly, as Tara mentioned, to tell the story of the community. And we'll talk a little bit exactly how we went about doing that in a minute.
Great. So what we did is we invited people with scleroderma to share their experiences through a short survey. We could apply we could write, we could use our voice or video record, and everything remained anonymous, of course. So we asked simple human questions like, what's your morning like with scleroderma? Because these small moments often reveal the biggest truths. To honour these voices while protecting privacy, we worked with the Melbourne Playback Theatre Company, an independent agency, to create a short awareness video using verbatim performance. So our words, actors performing exact words, true tone, emotion of the real people. The method reduced the burden, it safeguarded the identity of us and keeps the storytelling authentic and deeply felt as well.
Over 30 people from your community came forward to tell their stories, and they were from metropolitan but also regional places across Victoria, Queensland, New South Wales, WA, SA and also the ACT. So we had some pretty amazing coverage. Their honesty is really this campaign's compass. It was really, really powerful. Every single story told a part of somebody's journey. And it was a really daunting task to take these powerful stories and try and distill them into a 2-minute video, I can tell you. So we're really, really grateful to work with experts, the Playback Theatre. They have a really amazing track record in telling people's stories, specifically health conditions, health equity angles as well. So we worked with them to look at patterns and come up with archetypes to try and be able to manage to tell this really powerful story in 2 minutes. So we're going to go through a little of what this analysis looked like. So while we talk about these archetypes or these different types of journeys through scleroderma, I think we've heard already from Liz, these are not boxes. People move between them. It's not one person. It's hopefully an impression of what it's like to live with scleroderma. So one of them that we picked up, which was, I I think, covered a little earlier, the delayed and dismissed. So this is about the journey, the long journey, or the confusing journey to diagnosis, the years of misdirection, unanswered questions, and sometimes outright dismissal.
A quote, "Most GPs don't know anything about what I have and dismiss the serious impact on my life."
The next one was the unpredictable fighter. So this was about the daily negotiations, the good and the bad, the plans that were made and remade, and just that amazing grit just to keep going.
The hardest part is wanting to do more than my body will permit. It's hard living with an invisible disease and being told that you look so well.
The third one we settled on, which was the life rewritten, and this is about how scleroderma changes the way or reshapes the way you work, your relationships and your identity. And still, and amazingly, people adapt and self-advocate and are fierce.
Nothing is spontaneous anymore. I research everything before I go anywhere.
It was a real honour to work with the Playback Theatre, and we had a lot of back and forth conversations with them before we developed that trust, and I was very much an observer along the way. And I saw that the most important things that were part of this campaign that we needed to tell with this video was the cost of being complex. So this is one of those things that it's really hard to describe how scleroderma affects you, even to clinicians. This was one thing that came out. Even clinicians don't know what you're going through. The invisibility colliding with stigma, so the loneliness that comes, the humour and the wit. This is a community that really embrace humour, jokes, dark humour, your fierce advocates, and the way that you interact with each other and tell your stories is really powerful. And also the hunger for visibility, which is the core part of this campaign.
So this campaign's not just about empathy, it's also about change. So these stories call for better clinical awareness and coordinated care, so people aren't dismissed or lost in the system. It supports stronger research effort. It asks for faster access to emerging treatments because the status quo pathways just simply aren't good enough yet. It also asks for policy attention and resources that match the disease's complexity and impact. And so it was specifically designed for audiences, not just us, but health professionals, researchers, policy leaders, so the right people hear the message and act.
My family and friends are in denial that my body is being attacked from the inside because I look so well.
When I was about 20, my fingers would just turn white whenever the temperature changed. It was a cool party trick. 5 years later, I couldn't work. It took a random comment to my dermatologist for her to think outside the box and deliver a diagnosis.
Scleroderma. It's a connective tissue condition. It changes everything, from how much you can physically do before the pain gets too much, to what and when you can eat.
Every day is hard, and it seems like I'm fighting just to live my life. It's hard to ask others for help, but I'm learning and it's getting better. And I've learnt how strong I am.
I must admit, it's funny if I'm admitted to hospital and there are medical students there. They all come rushing in to ask questions, to learn more, because they don't get many scleroderma cases. I'm always happy to share my story.
A really big thank you to every single person who came forward to tell their story. Some people might hear their own voice, but every single person's voice has shaped the way that that story was told. So I just wanted to say a really big thank you.
And also thank you to our partners at Trial Screen and Scleroderma Research Friends, to the Melbourne Playback Theatre and to Valorum Media Productions. Again, thank you for the commitment, for the ethical, dignified storytelling, and to get these stories in front of people who most need to hear them.
So where's it going now? Is that on that website?
Yeah, we'll be releasing it after Sunflower Day.
Okay.
And yeah, then we'll be sending it out through the channels. So, yep. That it all started with the simple question of how was your morning? So thank you, everybody.
Just getting back into things, I just wanted to introduce Harry. So we've been associated with the Lung Foundation and working with them closely over the last, particularly 12 months. We worked with them to enable the men's online support group that we have available, which has been a fantastic effort. It took a while for the men to come out of the woodwork to actually want to meet, but we eventually got them there, so that was fantastic. So I'd like to now bring Harry up here to talk a little bit about the Lung Foundation and formally announce our wonderful partnership. So come on up, Harry. Thank you.
I'd like to also start by acknowledging the traditional owners of the lands on which we're meeting today and pay my respects to elders past and present. It's an absolute pleasure to be here, and thank you very much, Amanda, Tara and the board for inviting Lung Foundation to celebrate with you on this 20-year special day. And it's also a special time for Lung Foundation Australia. We are just about to launch our new corporate plan and our vision for the next 5 years of work at Lung Foundation Australia. And one of the things that is key to that work is very much about how we partner and partner more strongly. We really recognise that to achieve what we need to achieve, we do that when we work well with others, and that we, that saying of being stronger together is one that we believe strongly in. And our partnership with Scleroderma Australia is something that we will absolutely be focusing over the next 2 or 3 years as well. Just want to absolutely just say congratulations. 20 years is a fantastic achievement, and for a volunteer-based organisation that is even more significant. And I'm also aware that for many of the states and territories that's been longer than 20 years. It's wonderful to see all of us gathering in the room together to really listen, learn, and also commit to making a difference. And I love that terminology of changing lives, which is really a shared mission that we have at Lung Foundation Australia as well. And through the panel discussions that we've seen, so much resonates between the experience of people living with scleroderma, as we hear often with people who live with lung disease, that issue of being a visibility, that issue of feeling heard, but also feeling supported are things that are very important. And Jan, just the sunflower, I think, is a great example. One of my favourite paintings is The Sunflowers by Vincent van Gogh, and I think that when you look at that painting, you really do see that hope and courage and the joy underneath some of that sadness that we know Vincent experienced, and I think that's it really resonates about a lived experience of a condition. So I think you could not have chosen a better flower, although I do realise now that as part of the partnership I'm going to have to buy a yellow polo or something, so this is the best that I could do today, so I found something with a bit of yellow in it. But thank you again, and what a wonderful achievement. To talk about our partnership, and it really is about being equal partners. It really is about our shared mission and working together to change lives, but supporting people to live well is an important part of that. And being diagnosed with scleroderma lung disease is a life-changing event, and we know the time of diagnosis is a particularly challenging time for anybody, and it is about being like on a bit of a roller coaster that you actually never chose to go on. And at that particular time, there's a lot of questions that people have around where do I go, who is out there, what does this mean? People are looking for that information, support, and most importantly, connection. And I like that term of the tribe. Where is my new tribe? How do I find people who understand what this is like? And we know that to be true even when people are well connected with families and friends. It's not often well understood. And there's also that challenge where people don't want to feel like they are overburdening their families. So finding people who are going through what you're going through and connecting on that level is a really important part of what we will do together as part of this partnership. And the most important thing we do is meeting people where they're at. So, and that's, I think, critical to what Scleroderma Australia does and also what Lung Foundation Australia does in that way. So it's understanding and feeling listened to and heard. And this is not a criticism of our wonderful healthcare professionals, but it is about time, and it is about that understanding, and it is about that focus and feeling understood. We know organisations like Scleroderma and Lung Foundation Australia, that's our key strength. And building out this partnership means that we will do that more strongly together. And it is about trust at the end of the day. It really is about trust. And we know that through this partnership, we will build that stronger trust together. Just wanted to go through what that means in real terms for our key aims over the next 2 to 3 years, recognising that we've already taken some great inroads. And I also want to recognise that roundtable that we had that with the support of Boehringer Ingelheim, which was really for me a light bulb moment when we had the rheumatologists in the room and the rest, and the respiratory specialists, and both Scleroderma and Trish, who's our one of our wonderful consumers who lives with pulmonary fibrosis. And it was just one of those light bulb moments about how we really need to start working together more strongly. And I was really surprised by the statistic that 1 in 3 people, and might be even higher than that, who have scleroderma will go on to develop pulmonary fibrosis or PAH, and that we don't screen for that routinely. And the flip side of that also, that if someone has a diagnosis of pulmonary fibrosis, we are not routinely, again, ensuring that people are tested for connective tissue disorders and others. So a lot of the aims that you'll see us working through are really designed about how we're going to continue to raise that awareness, and a real credit for lighting up Australia in yellow, and great to see that happening more and more. Facilitating those pathways to early diagnosis, and we know the frustration that people have in delayed diagnosis. It is prolonging suffering. It also means that treatment starts later, and a whole range of circumstances that follow on from that. That multidisciplinary team approach and that wraparound, and I know we'll be discussing that more today, absolutely important for people to get the care that they need at the right time, in the right place, and that it's coordinated. And the other areas that we have is really about primary care. We know from the lived experience work that we did at Lung Foundation Australia that people will go to their GP. Primary care is their first point of call, as it should be, around symptomology. But that for many people it can take 5+ visits to their GP to feel like they're being heard and investigated. And we hear a lot about people wanting to have a curious GP that works with people and the symptoms they're presenting with. And I heard again that today, and that's very similar with people with an experience of lung disease. That improved coordination of care and information. You do have to become a specialist health navigator when you have a diagnosis, and recognising that we as a healthcare system need to make that a lot more streamlined for people. That right information and that support that we can offer as two organisations working more strongly together. And that champion consumer-led research, and again I heard that this morning, where priorities that matter most to people are the ones that we also want research to be focusing on. And we know our community, and I know the scleroderma community as well, absolutely appreciates how important research is, more new drugs on the market, but also the wraparound care that comes with that as well, and how we champion that together. And just the other thing which is really important for us as well is really about how we become a trusted source of information for people. And I think now more than ever, with all of that disinformation and concerning information that's out there, people will go out to Dr. Google as the first point of call. But knowing that organisations like Scleroderma and Lung Foundation are there and a trusted source of information, I think will become more and more important. And just the final slide was really about our partnership in action. So we talk about aims and objectives and all the principles behind that, but these are the areas that we really we'll work on and that you can all expect to see more of coming to life. So, you know, how do we share opportunities for education? How do we co-design our resources, and how do we make sure that those resources are relevant? Using our influence in that healthcare space between rheumatology and respirology, and how we bring people together, those peer support programs and connecting people with lived experience, that streamlined cross referrals between our organisations, the wonderful nursing services that you offer and we also offer at Lung Foundation Australia, and you know, a real focus on that primary care and how we help GPs to understand the importance of the symptomology and how that needs to be investigated. But that, for us, really, it is about the heart of this is that shared consumer insights to ensure that we are addressing the things that matter most to people. And having lived experience as, I guess, the guiding light for our work is a really strong connection that we will do together with Scleroderma Australia. And I couldn't be happier to work with Amanda and Tara, who have been such a lovely couple of people to work with on all of these areas that we're passionate about. So thank you, Amanda, and thank you to the board as well for building this partnership with Lung Foundation Australia. Thank you.
You'll notice that sneakily we didn't put that on the agenda. We did that on purpose, just like with you and Ian and Marilyn. So yeah, very, very happy to have this partnership happening and launching it today, especially on our significant 20th anniversary. So thank you again. Please send my best to Mark and let him know that we are extremely proud and pleased to have this announcement. So next part of the agenda, we are going to be moving to a panel discussion. I would like to introduce this panel discussion when the slide comes up. Great, thank you. Perfect. So our next focus is delivering better outcomes through multidisciplinary clinics. Again, we've kind of heard that theme this morning, talking about it a few times. So we're going to look at how bringing specialists together in a coordinated, multidisciplinary way can transform diagnosis, streamline treatment, and ultimately improve quality of life for those living with scleroderma. I'd like to introduce to you, that's me now, it's my pleasure to introduce, and I'm sure everybody in this room will know, Professor Mandy Nick-Paul, often adorably known as Dr. Mandy. We absolutely love Dr. Mandy. Dr. Mandy is the chair of the Australian Scleroderma Interest Group. She's an amazing scleroderma champion. She's got lots of accolades under her belt. I will read out a few. She's currently a rheumatologist at the Royal Prince Alfred Hospital in Sydney. They stole her away from Victoria, unfortunately. Not particularly happy about that, Mandy, but good for Sydney. Good for Sydney. And also a fellow of the Australian Academy of Health and Medical Sciences. She's been widely recognised for her research excellence with interest spanning lupus and scleroderma cohort studies, translational research and clinical trials of emerging therapies. So please welcome Professor Mandy.
Thank you very much for that very kind introduction, Amanda. It is actually my absolute pleasure and privilege to be here with you today. As many of you, if not all, will know, scleroderma is really one of my absolute passions. It's something that I have dedicated the large part of my career to. It is a field of clinical care and research from which I draw immense inspiration, and I can tell you that I love each and every day of my work. I am most inspired by our patients, and you know, I feel that the work that Scleroderma Australia has done over the last 20 years has been incredibly instrumental to our success, from partnering with us to design research studies that are clinically meaningful and relevant to our patients, to raising funds for all of our research, from projects to PhD scholarships, and the list goes on. We've really grown, the Australian Scleroderma Interest Group and Scleroderma Australia have really grown side by side, because we will be celebrating our 20th anniversary next year. And I hope to see many of you there. So it's been a journey that we have made in partnership, and it's really seen a lot of advances in scleroderma. I can tell you that over the last 20 years, so much about the way we manage scleroderma has improved for the better, and we are truly seeing better outcomes for people affected by this condition. We still have a long way to go. I still have to explain to my neighbours what scleroderma is when they ask me what I do, and I stop and I do it, and then sometimes they sort of think, oh, maybe we shouldn't have asked what that was. But the word has to spread, and the passion has to be there when we talk about this condition and our dedication to improving its outcomes. So it's really on that note that we're going to launch into our panel discussion. And to begin that, we're very fortunate to have a recorded video that was made specifically for this audience and this occasion by one of my dear colleagues and world-renowned scleroderma expert and researcher, Professor Anna Hoffmann-Vold. And Anna is the head of inflammatory and fibrotic rheumatic disease research at Oslo University Hospital in Norway. And she also has a translational research appointment at the University of Zurich in Switzerland. And she has been really involved in a lot of the research in scleroderma, particularly around the interstitial lung disease space. And one of her real research interests and areas that she has championed is multidisciplinary clinics in scleroderma. And so without further ado, we're going to start off with this recorded video by Anna, which will then be followed by our panel discussion. We have some wonderful panelists that I will introduce to you shortly. So here we go. Do I press or do we? Yes, I can press to get it going. Yeah.
Hello everyone, I'm Anna Hoffmann-Vold, a rheumatologist from the Oslo University Hospital, and I'm delighted to talk about the role and responsibility of us rheumatologists in a multidisciplinary team meeting around patients with systemic sclerosis and interstitial lung disease. Very sad that I can't be with you in Australia. I would have been loved to be there. I was visiting your beautiful country last year in August, and I really hope that I will be able to come back in the future. So here are my disclosures. And what I think is really important to highlight is that systemic sclerosis has really become in the focus of us physicians, caregivers, you patients, other healthcare providers. And this is really mirrored by looking at how many guidelines and recommendations have been conducted and published the last years. Here you can see it's actually 4, either specific on systemic sclerosis, such as the updated EULA systemic sclerosis treatment guideline, or the 2023 ATS guideline of treatment of systemic sclerosis associated interstitial lung disease. But also here on the left-hand side, the 2 guidelines, one from the ERS and EULA and one from ACR Chest, looking at interstitial lung disease across all rheumatic diseases, including systemic sclerosis. And I think this is really exciting for all of us, knowing that we are standardizing the management of our patients across the world. And when we talk about interstitial lung disease, I always think it's so important that also everyone understands that it is a frequent manifestation in systemic sclerosis, regardless of what kind of skin manifestation exists. So both in the patients who have diffuse skin disease and who have limited skin disease, interstitial lung disease frequently develops. Yes, as you can see here in dark blue, it develops somewhat more frequently in patients with a diffuse skin subset, but also here 45%, so nearly half of our patients with a limited skin disease develop interstitial lung disease. So it is really, really important to think interstitial lung disease, and also for you as patients and patient providers for other patients, it is really important to tell all the patients, regardless of skin subset, that they should be aware of that their lung should be assessed for the presence of interstitial lung disease. And why this is so important is really based on that we know once there is lung fibrosis shown on the HRCT image, mortality is higher. So we really want to know that is there so that we can intervene, treat, and do as good as we can. And therefore, I think it's really important to understand why we rheumatologists are so important, because we usually see in every country around the world patients with systemic sclerosis often as the first contact in the specialty care. And here we need to remember to screen all patients. And this is what I told you, regardless of what kind of skin disease to have, whatever systemic sclerosis patient you are, systemic sclerosis in itself is a high enough risk to develop interstitial lung disease. So therefore, all patients should be screened. And that is also something we, again, recommended in our 2025 ERS EULA clinical practice guideline. So that means that systemic sclerosis in itself is a high enough risk to develop interstitial lung disease, and therefore all patients should receive an HRCT. And then, of course, in addition, we should look at how does the lung function behave, and also whether there are respiratory symptoms such as dyspnea and cough. And then what is the role of us rheumatologists in the diagnosis? And what I think is very important is that all patients should also be looked at from different specialties. And even if we rheumatologists mostly are the central care of systemic sclerosis patients, it is very important that we also work with other specialties. So for example, we should always, if a patient has interstitial lung disease, consider working with a pulmonologist here in the middle, also a radiologist, maybe a pathologist if samples from the lungs are taken, also other specialties such as clinical nurses and physiotherapists, occupational therapists. And all of us should lead together the care of all patients so that the patient has the best quality of life and the patient is managed the best way. And here I think the rheumatologist really also plays a pivotal role, and I will tell you throughout the entire talk here why I think so. And, you know, I can mean as much as I want, and I really want the best for my patients. And of course, I would also want to collaborate with colleagues. But I think often it's very important to understand, are there also data showing that it is an improvement if rheumatologists are involved? So I was looking through the literature, what is published, and I found actually some very interesting publications who shows the impact of including a rheumatologist in the holistic care of patients with systemic sclerosis, interstitial lung disease. The first row really shows that patients who were diagnosed with idiopathic pulmonary fibrosis, so saying they have lung fibrosis but no underlying rheumatic disease, in 21 to 28 cases, the diagnosis was changed from idiopathic pulmonary fibrosis to a rheumatic disease and associated interstitial lung disease. So we really make an impact of the right diagnosis. It was also seen that 36% changed their diagnosis to an alternative rheumatic disease, which is also important because we would treat and manage patients with a systemic sclerosis patient different than a patient with myositis or rheumatoid arthritis or Sjogren disease. And then we also saw that in general, rheumatic disease-associated interstitial lung disease, the diagnosis increased from 10 to 21%. So most likely also telling that we need to screen and then we identify interstitial lung disease more. And then also, as you know, there are also some patients called interstitial lung disease with autoimmune features. So they don't really have a diagnosis of a rheumatic disease, but some flavors of autoimmunity. And also these cases actually increased by 77%. So all over that shows by adding a rheumatologist to such a meeting or such a multidisciplinary team approach, we really make an impact on the right diagnosis. However, a real challenge in clinical practice is that there's a weak agreement between specialties still. And of course, we can't really say we rheumatologists are the gold standard. Well, maybe Mandy and I would say so, but of course, we can't really say this. So there is still a quite large disagreement when you have different specialties talking to each other. And maybe also several patients have experienced this. So for example, here, if you look at autoimmune test positivity, there is only a very modest agreement between specialties. Or if you look at whether there's a presence of extrapulmonary symptoms, there's actually a weak correlation between specialists. So that might be that I, as a rheumatologist, would say the patient does have arthritis, but a different specialty looking at the patient would say there is no arthritis. But that also, to me, supports again that we need to work together so that we really get the right answer for this every single patient. And then in the next part, I really want to talk a little bit about what the rheumatologist can add to the monitoring of patients with systemic sclerosis and interstitial lung disease. And my major point is really highlighting that we rheumatologists, we have always a holistic approach with patients. So we are coming from internal medicine, and we are not a subspecialty within internal medicine, such as a pulmonary or respiratory physician would mostly look at the lung, a kidney doctor would look at the kidney, and so on. We are trained to mostly look at all organs in the patient. And this is so important because we know that systemic sclerosis is a multi-organ disease. And most patients will mostly have more than just one organ involved, and especially patients with a lung. So here I just want to show you also, or supporting what I was just saying. So here in red, the box, you have a systemic sclerosis patient who is positive for anti-TORPRS+1 antibody or anti-SCL70. And then here on the plot B, which I have highlighted in red, you can see such a patient with systemic sclerosis, interstitial lung disease, and positivity for this autoantibody also has an 82% skin involvement, an 85% GI involvement, so gastrointestinal symptoms, and 83% also digital ulcers, and 31% that patient might develop pulmonary hypertension, and then 2% that patient might develop also renal crisis. So that really shows the probability of a patient with such a profile to have other organs is super, super high. And of course, this is why rheumatologists who are trained to look at all the organs really can have an impact on the monitoring. That is also highlighted by that we actually published a minimal set of organ domains which should be monitored every single year. This was now published in 2019, and there was 10 different domains which should be checked in every patient as a monitoring over time. So here you can see we should always check the treatment, we should always check lung involvement, GI involvement, digital ulcers, skin involvement. Here the labs, the heart, venous phenomenon, the kidneys, and the muscles or musculoskeletal organ domains such as arthritis and myalgias should always be at every visit, at every year, be assessed. So that really tells us that if you have several specialties included, you will cover this, but the rheumatologist will also always make sure that these organs are covered in the annual monitoring. And also, for example, many of you will also have been assessed by the Rodnan Skin Score, which you know is to assess the skin. We pinch and punch and lift the skin and see how severely involved the skin is. And that is in 17 body areas, gives a score between 0 and 51. And this is also something you really need training in. And if you have an SSC rheumatology expert, we do this all the time and we are really used to this. So this is also what we can add to a multidisciplinary team and what we do every year. And why this is important for the follow-up of systemic sclerosis patients is that we know it is also a risk factor for increasing or progression of interstitial lung disease. Here in the lower or in the right bubble, lower line, you can really see recent onset of systemic sclerosis with rapid skin worsening or extensive skin fibrosis. These patients have a higher likelihood of getting worse in their interstitial lung disease as well. And this is what we can assess and also make chart notes and really highlight that is a patient with a lot of skin, so we also need to be worried about the lung. Other risk factors which we found when we looked at risk factors were mere sex, older age, increased inflammation, such as circulating CRP and ESR, which are measures for inflammation in the blood, anti-topoisomerase 1 antibodies, and also lung function and extent of interstitial lung disease, so extent of lung fibrosis on HSCT. So all of these are important to assess every year. And again, we rheumatologists are important to do the Rodnan skin score and to tell also colleagues that a patient is at higher likelihood of a worsening of lung fibrosis. Then I really also want to highlight a little bit what we as rheumatologists can add to treatment decisions and changing treatments once we work together with colleagues in the management of patients with systemic sclerosis-associated interstitial lung disease. I think something which is very positive and which I think is both for us treating patients, but also for patients in itself, really important to understand. We have increased the number of patients treated from early times before 2007, which you can see here was only 14% were treated, until after 2016, where 57% of all patients are treated, is really a progress. So we consider treatment in a much higher amount of patients, and we adapt treatments across the time periods. So every time we get a treatment which is tested in a randomized trial, we use that more in clinics. And that is very good for patients because then these drugs have been tested and are applied in clinics, and we know that they are efficacious and the side effect profile is tolerable. So one of these examples is mycophenolate here in pink, which you can see. The study was published in 2016. So after 2016, also before, it was only used in 3 and 5%, here in 14%, and after the publication in 24% of patients. So it really shows we adapt our treatments, adapting to the randomized trials, approved therapies, or treatments shown in trials. So again, back a little bit to the evidence, what changes when a rheumatologist is included in such multidisciplinary team discussions? Well, one of the first one is a little bit surprising because also therapy for idiopathic pulmonary fibrosis, so patients we actually don't see, changed in 27%. I think this is a little bit related to maybe that the diagnosis has also changed. Otherwise, we wouldn't have that big of an impact. But what also is very interesting is 55 to 80% therapy was changed for rheumatic disease, interstitial lung disease. I also think a little bit it is back to what I told earlier, that we change the diagnosis of the underlying rheumatic disease, and that of course also may lead to a change of treatment. Then once adding rheumatologists, the use of corticosteroids is decreased from 36 to 28%. Immunosuppression in itself has increased from 7 to 17%, and clinical trial inclusion is increased from 0 to 3%. So you can really see it's a very specific impact once we discuss patients. Antifibrotic therapy also increased, and oxygen use increase. And I think that is because we discuss also and have a conclusion how severe a patient is and how we can adapt treatment. And then, of course, what we also do, as I told you, that we have these 10 domains which we check every single year when the patient comes to us for the annual visit, we always also look at treatment. And here we use also the updated EULA treatment guidelines, and we look if a patient has several organs involved which need treatment, we can use these guidelines to really see which drug covers several organs. So for example, here, if you have a patient with interstitial lung disease who also has skin fibrosis, we would see, for example, that rituximab or mycophenolate or tocilizumab are drugs included in the guideline. So we would choose one of these treatments who cover several organs. This is also why we really have an impact, because we do map all the organs, and that leads to treatment changes. Then also there are published guidelines for non-pharmacological therapies. And I think this is really, really important that we always consider what else can we do. And this is also very much when we work together, especially also with specialized nurses, physiotherapists, occupational therapists, that we think of this holistic approach other than pharmacological therapy. So of course, it is always important that patient education, self-management support. This is also where you as a patient organization are really, really important to work with us, that we really increase the availability for material, that we inform patients what is available. Smoking cessation is something we would always mention. Avoidance of cold exposure if a patient has Raynaud's. Physical exercise, often optimized for the individual patient. Improving hand function, improving mouth-related outcomes, often working with occupational therapists. Manual lymph drainage, often if patient has trouble with that, and improving health-related quality of life. And I think especially these approaches are very, very important to have a good collaboration with patient organizations, to also understand what is the need of patient, what else can we do, how can we support together our patients. I also think it is very important, because I showed you some of the data, how we change actually ongoing treatment. But what is also very clear is once we sit together and discuss patients, other treatments such as here below lung rehabilitation and transplantation assessment increases. And you can see here in this specific study, no patient was referred to rehabilitation or lung transplant assessment before such a multidisciplinary team. But after that, the numbers increased to 5 and 16% of patients. So I really think that is also always an important part. And then, of course, there is no ideal MDT. When I was in Australia last year, I was really amazed how all your centers, which I visited, Brisbane, Sydney, Melbourne, all had these good MDT meetings, including rheumatologists, but also slightly differed how they actually work together. And this is the same in my country, across Europe, across the world. And that is important to understand. There is not one size fits all. We really need to adapt it to the single center, to the country, to availabilities and whatsoever. But there are many different ways. So we can sit together in clinic, or we can make a telephone call, or we can have a virtual meeting or an on-site meeting where we discuss patients. So all of them, there's not one better than the other. It really needs to be adapted, and there are many, many possibilities. So if there's a place in Australia where it's not possible, I think it's important to link it to the bigger centers and really evaluate how can we also support more rural areas. So my take-home messages are that interstitial lung disease is a frequent and severe manifestation. We rheumatologists need to screen. That is our role, and this is where we really can make an impact. Multidisciplinary team plays, with except for screening, also a major role in diagnosis and monitoring and treatment. I showed you that both the diagnoses often are changed, both on the underlying rheumatic disease, but also more idiopathic pulmonary fibrosis patients suddenly get a rheumatic disease diagnosis. Also, we need to remember there are many different treatment options, and we give an impact on changing treatment patterns over time. And importantly, there are many options how to create and how to work together. There is not one one-size-fits-all approach, and there's also not one better than the other. It really needs to be adapted. So thank you very much for listening to me, and I'm excited that you have Mandy and the team on site who also can answer if you have any questions to my talk. Hope to see you all soon again in Australia, and enjoy your day. Goodbye.
Fantastic presentation from Anna to set the scene for our panel discussion. So I'd like to invite our panellists up while I introduce them all. Please join me. We have a seat for all four of you. So we have Professor Edmund Lau, who is a respiratory physician working at Royal Prince Alfred Hospital, Sydney. He is a professor of medicine at the University of Sydney, the lead respiratory physician of the Pulmonary Hypertension Service at RPA Hospital, and has worked in a postdoc capacity at the French National Referral Centre for Severe Pulmonary Hypertension. He's a medical director of the Australia-New Zealand Pulmonary Hypertension Registry. We have Dr. Anthula Muhammad Ali, who's a specialist palliative care physician and the current RPA head of the Department of Palliative and Supportive Care, and runs a clinic with the statewide ILD, so interstitial lung disease service at RPA, where she sees a lot of patients with scleroderma And we also have Suzanne Webster, who's a clinical nurse consultant. Suzanne, wave to the crowd so they know who you are. She is a clinical nurse consultant also in the interstitial lung disease clinic at RPA Hospital Sydney, and has worked in this area for 14 years, passionate about providing evidence-based care to patients and their loved ones, and has a special interest in patient education and advocacy. We have our wonderful consumer representative, Janelle, who is the Administrative Officer for Scleroderma Victoria, serves as a support group coordinator across Victoria, Tasmania, South Australia and WA, so very broad geographic area that you cover. A valued member of Scleroderma Victoria Committee for more than 5 years, has contributed a lot of her time and energy and insights to strengthen community connections. So I just wanted to kickstart the discussions. We do have some microphones, and I believe there's this one here too, so we're hoping that we'll be able to get some comments and insights, questions from the audience. But to get the ball rolling, I actually wanted to put Suzanne on the spot as the first person to kickstart the discussions. Suzanne, as a nurse, tell us about what you think is special and good and works really well in the multidisciplinary clinic that you work in.
Thank you for the opportunity to be with you here today, and also to talk about the wins of working in a multidisciplinary team. As far as our clinic is concerned, we have operated since 2011 at RPA as an interstitial lung disease service, and so we see patients with ILD for all different reasons, including scleroderma. And since its very inception, we've had a multidisciplinary focus, with the clinic always having been staffed by doctors, nurses and physiotherapists. But that's a professional multidisciplinary team, so there's lots of different, but we all came from a respiratory background. And I think the true strength of our clinic didn't really come into its true strength until we started to involve other disciplines. And the first one was in 2016 when Professor Jane Bleasel joined us, and we created a combined rheumatology service. So it was really at that time that our interest in providing, and I love the term used earlier, of wraparound care, Anne Thuller and I both wrote that down at exactly the same time, and I've always referred to it as a one-stop shop, so an idea that patients have the right to come to one physical location, and for us as the care providers to be the ones that provide that care all in the one place. And whenever I talk about our centre, I think it's really important to make the point that we're extremely fortunate to have the resources and the support of our institution to be able to provide this care. Many of your clinicians would absolutely want for this care to be provided in this way, but resourcing doesn't always allow it. So if you are existing in a centre where there's not as large a multidisciplinary team, it's not because of lack of will or a desire from your clinicians to want to work in a multidisciplinary team. It's typically a resource problem. Over that time, the other gains would be adding a palliative care service, which Dr. Muhammad Ali now leads, and our clinical genetics, and lots of other different specialties. So having a real belief in this idea that patients deserve to turn up to one physical location and for us to come to them rather than the other way around has really been a realisation of our belief in providing true patient-centred care.
Thank you. Thanks very much, Suzanne. That was very well articulated. And we'll come back to what you've touched on, which is the palliative or supportive care shortly. But I next wanted to ask Janelle, from your perspective, having heard what Suzanne has said, tell us about some of your observations, insights, experiences, and very happy for you to weave in not only the wonderful things, but some of the challenges that there might be, some of the unmet needs.
Thank you. I've been under the Scleroderma Clinic for nearly 10 years, so originally diagnosed by a gastroenterologist and gone to a rheumatologist that was referred to them. I think it's good because I'm living regional, so I've got to travel to a clinic, but they coordinate all the tests, so your lung tests, your heart tests, your blood tests, those sort of things. They also can interpret the tests a lot better than what, on personal experience, other rheumatologists can do, and your GP, who is sort of outside of their reach to understand the tests. They can also get you to have tests like the NT-Pro test that GPs forget about, or just your vitamin type test, those things. A couple of challenges I've had are travelling. A lot of us that are diagnosed will have brain fog or fatigue and things like that. So you're also nervous going to see a rheumatologist and get your results because you're always thinking the worst, not the best. But I've had the same doctor for 10 years, so that puts you at ease. One of the things I've had is the scleroderma nurse. Originally, when I went up to St Vincent's, I had a dedicated scleroderma nurse who could identify if you were struggling or having issues, and she would take you to your appointments with you, do your 3-minute walk test, that sort of stuff. You could also contact them afterwards if you had some other questions to ask instead of bothering the rheumatologist, and then if that was urgent, she would contact the rheumatologist for you. The new scleroderma nurse I have not seen in a couple of years, so that's sort of missing for a lot of patients and things like that. But yeah, they're mainly my challenges.
Yeah, thank you, Janelle. And I guess, the scleroderma nurse is a wonderful person who can actually, I guess, help you navigate your care, right? And maybe wound care.
Yeah, and I think they're
ulcer
in
dressings.
between.
Yes.
So instead of, say, I've got an issue, I've just had a question about a result in the blood test or something like that, instead of having to wait 6 months for your next appointment, you can ring them, or if you've got a wound care issue or an ulcer, your GP can actually ring them and get advice as well, or your GP's nurse can ring them and get advice, which I've had done. And they know that advice they're getting is scleroderma related, not just everything related. And I think that makes a difference because you've just got a bit more confidence and they put you a little bit more at ease.
Yes, thank you very much for sharing that. Edmund, I was going to come to you. I'm actually very privileged to work with Suzanne, with Edmund and with Anthula in the interstitial lung disease clinic, but also the pulmonary hypertension clinic, the multidisciplinary pulmonary hypertension clinic. Edmund, do you think you could perhaps briefly describe the setup in that clinic, which is a little bit different, isn't it, to the ILD clinic where the rheumatologists, respiratory physicians have their own list and see the patients. They go from one doctor to the next. The setup in the pulmonary hypertension multidisciplinary clinic is a little different. And then in describing it, also please tell us some of the great things about it and some of the challenges.
Yeah, so since the inception in 2006 when therapies became available for pulmonary hypertension in Australia, we've had a clinic set up where we call it our once a month multidisciplinary big clinic. And what we do is we actually have at least one lung specialist, one heart specialist, and one rheumatologist. And we actually see all our patients together at once. And then we assess the patient, we look at them, we look at all the results, scans, right heart catheter results, echocardiogram, and then we come to a consensus on how we actually manage the patients. And I think similar to what Suzanne described, it's really like having a mini MDT at the clinic. And you get the output of the MDT almost straight away. And it's very efficient and effective in getting, I guess, the minds of multiple doctors together to manage some of our really quite complicated patients. And to be honest, even though I'm a lung specialist and have some idea about perhaps immunosuppression, really we are not that familiar, and having someone like Mandy there, is really, really helpful. And also just providing a holistic care of the patient, because most of our patients have multi-organ disease. And so even though as a lung specialist we look at the lungs, we have to be very mindful whether our drugs might actually cause problems elsewhere, like diarrhea, etc. So this model has worked well for us, but it is a very, very labor-intensive model. And it's not really something that I guess, it's nice to be able to be replicated, but I think a lot of other hospitals may find it hard to pull everyone together all at once. And it's really just having the goodwill of, my colleagues like Mandy and my cardiology colleagues that are happy to come together that actually allow this clinic to be possible. Look, I guess not all models are perfect. Probably one drawback of our model is that the clinic room does become a little bit crowded. As you can imagine, there's 3 or 4 doctors and the patient and their family. And sometimes, if a patient is very, very sick and maybe reaching the terminal stages of the disease, we kind of do have to just step out and have a more one-on-one discussion. So I think that there are some scenarios where it's not really conducive to this kind of setup, and we're very aware of that. So sometimes if there's a patient where we need a really important, private conversation, then we just see the patient one-on-one. And I think probably not all hospitals would have the resources to actually set up clinics like this, and in some way it is a problem across the board that at least in New South Wales Health, funding is a big issue. So it is a problem that we're always facing against. So I think those are probably the main points. Mandy?
Yes, thank you, Edmund. Very well summarised. And I guess, you touch on something very important, which is how do we make a compelling case for having resources to have multidisciplinary clinics? A lot of it, as you said, rests on generosity and goodwill of all those that are involved. But I also think that there is definitely room for advocacy and for showing that it does improve patient experience of their condition and also their outcomes.
Yeah. Look, absolutely. I think that, because there's many patients here today, I think advocacy is extremely important, particularly in Australia. Look, I work in the pulmonary hypertension field, and just as an example, the new pulmonary hypertension drugs are always approved many years after initial FDA approval. For example, the last medication that was approved is Uptravi. FDA approval was 2015, and it did not arrive in Australia until 2021 with reimbursement. And similarly, the newest medication called sotatercept, some may have heard of it if you have pulmonary hypertension. It's been FDA approved since 2024, and we're still going through the process of trying to convince the government to reimburse it. So I think this is really an area where patient advocacy is really, really important, and I guess the doctors can jump up and down, but I think politicians and administrators do listen to patients, and their concerns. So Mandy, that's really, really important. Yeah.
Thank you, Edmund. Thank you. So we'll continue our discussions because we've got the green light to go to 10 past the hour. And so I'd like to now ask Anthula for her comments and insights. I was actually going to ask you, Anthula, what is palliative care? And how do you see it in this context of a complex multi-organ disease that has a major impact on health-related quality of life, physical function, really throughout the disease, right? Please.
Thanks, Mandy. So good afternoon, everybody. I think, often there's a misconception and fear around palliative care, that it is for people who are at the end of their lives, and that's really changed in the last 30 years. So what is palliative care? Palliative care is part of healthcare where we focus on 2 aspects. Health-related suffering, so we're trying to relieve suffering, irrespective of the diagnosis or prognosis. So health-related suffering and quality of life. So we look at not just the person, the patient, but those around them, their carers. We look at physical aspects, so particularly in scleroderma and interstitial lung disease, so breathlessness, pain, fatigue, cough. But there's also the other fundamental parts that make life, worth living. And what I think one of the previous panel members had said is to lead a happy and productive life. So aspects of social life. So, how do you live a productive and meaningful life, and how do your carers cope? There's the psychological aspect. So adjusting to what is a chronic disease and how to live with that, and also the grief that people often experience. You thought life was going to take you one way, but in fact it's very different for you and for your carers. And then the spiritual domain. So we have always provided wraparound care in palliative care. We've always worked with a multidisciplinary team, and probably one of the least effective members of the team is the doctor. We're heavily reliant on our nurses, physiotherapists, occupational therapists, social workers.
Thank you, Anthula. And I think you touched right at the end on what, I don't know, broadly referred to as allied health, so physio, occupational therapists, social workers, and I think they're a very important element in all of this. Really, if once I sat down with one of our registrars and we thought, what would our ideal model of a multidisciplinary care clinic look like? And it really was a village. It was a very large cast of healthcare workers delivering care, and I don't know that that's realistic. I guess we have to be somewhat selective, but and think about that, the fact that all of those services are needed, but maybe we can't deliver them all in one clinic.
I mean, that's overwhelming for the patient. And a lot of what, Suzanne helps us with this is to, when we meet the patient, we meet them where they're at and then try and establish what their needs and then link them into the appropriate members of the team. I think there are gains to be made in a one-stop shop, but sometimes many of our patients, particularly with scleroderma, are exhausted much of the time. So it's trying to pace what, how we assess people and then how we can provide the resources. I hate to say it, but although resources are limited in palliative care, we've actually had a flood of funding for the last couple of years, particularly focusing on people who are living with non-cancer diseases. So wherever you may be, whichever state or territory, there is a local palliative care service that is available, and I'm happy to give people contact details. They may not have the full panel of professionals, but that we do have funding. It is reaching even regional and remote areas, including where we provide outreach.
Thank you, Anthula. I think that's a huge win, right? Greater investment in palliative or supportive care. I just wanted to invite the audience, if there's anyone who wants to make a comment or ask a question. And while you're preparing for that, I just wanted to ask the panel overall about the multidisciplinary team meetings. So that was something that was also touched on. And we have those in the ILD space, we have them in the pulmonary hypertension space. I was wondering, Suzanne, maybe if you could make a comment, and then Anthula and Edmund, if you could just comment. And I think one of the things that Anna also pointed out was that not every major not every hospital has an MDT meeting, so one of the things that we've done at RPA is to invite those from elsewhere to also bring cases so that we can share our expertise and knowledge. If you could.
Yeah, that's correct. So in both the ILD and the PHMDT, we're dealing with rare diseases. These aren't large population diseases, and so where there are resources, it's really necessary for those people providing those resources to be collaborative and to open up their services for access from outside of our particular centre. Patients don't need to travel all the way to, in our case, RPA to get the same kind of care. And if we have a belief in health equity and the provision of service to people regardless of where their Medicare card is issued, then it's incumbent on us to provide that service and provide that in a way that is truly accessible. So our meeting, it looks like it's an online meeting, and COVID was the impetus for us to go fully online. And the four of us sit in this meeting every Thursday morning, and we have people from Dubbo, from Eden on the far south coast,
And many years ago, about 10 years ago, a physician started up a service in Newcastle, and so they now cover the northern part of the state. And that was really important for us because it allowed us to, we shared our model, we went and spoke with them, we physically went there and helped them set up their service, and now that hub and spoke model out of John Hunter really covers that area as well, and that's really in rare diseases, and I'm sure Edmund would agree with me, it's important that we share our models of care and allow other people to replicate what we do and be as open and accessible as possible. But in that meeting, Anthula and Edmund from a pulmonary hypertension perspective, and there are lots of other people who have occupational lung disease expertise, and everyone gets an opportunity to offer their opinion about both diagnosis and management. So not all MDTs talk about management, ours does, and in those cases, commentary from Anthula is almost always, extremely important in discussing even especially the trickier cases.
Yes, thank you, Suzanne. Edmund and Anthula, did you want to make any additional comments there?
Look, just a really quick comment on the geography of Australia and why having MDT online has really, I think, transformed the way we manage a lot of patients. So New South Wales is a massive state, Queensland, WA even bigger, and for a lot of patients it's just not feasible for them to actually travel to Sydney to see a specialist because some of them could be very, very sick. For example, I just saw a patient a month ago that actually lives in close to Bourke in New South Wales. And so I saw her in Orange, which was 4 or 5 hours away from where she lived, and she had severe pulmonary hypertension due to scleroderma. And I guess really without having some kind of a hub and spoke and remote MDT approach, it is really, really hard to sort these patients out. And yes, ideally, we do like to see them face to face, but it's just not possible for the patient to come to Sydney all the time. So I think nowadays, having this MDT model where we can actually reach out to regional Australia and the local physicians can have links with us and ask for help if they need, I think has been like really, really important progress. And it kind of COVID helped that, as Suzanne said.
Anthula, any additional comments from you?
Oh, one simple but high impact factor is, when you're a patient or a loved one dealing with the health system, it can feel like you're dealing with Telstra. So you talk to one person, you tell them your story. Then you talk to another one and you're answering the same questions and again and again and again. And being part of the multidisciplinary team meeting, I have very little input. The power for me is actually hearing everyone's decisions, opinions, so that when I see a patient or speak to them on the phone, we provide telehealth, is the patient say, you already know that. Yes, I do, because we've already shared your story and we understand the challenges. So I think that may seem like a trivial factor, but I think that is a very high impact intervention around the role of the MDT when we're caring for humans at the end of the day, not a disease.
Yes, absolutely. And I think you also touched on the fact that, it's the carers as well, the family, that broader group, the network of support that these individuals have, that's also included in our discussions and in that supportive care. I'd like Janelle to have the last word, and I was going to ask you, Janelle, what do you want us to know? What is our call for action? What should we be doing, and what can we all take away from our discussion today in terms of things to do?
Do you mean as in change, or what you would like the doctor to know before you walk in the door? What do you mean?
Well, I'm just saying, what do you want us to do to make things better when it comes to multidisciplinary care?
One thing I like is that the patient knows that you all have a team meeting, because that's not always told to us until maybe a year passed and something goes wrong and they say, we just had a team meeting about you. but we have no idea who's in the team meeting, what they're discussing, and we might be making things up in our head thinking the worst, but it might not be that. It might just be a new drug that's on the market or something like that, or a new trial. So I just think more communication is needed, especially for patients, especially new patients. The other thing that needs is that carers are included, so that they're also spoken to, not just... I've been to appointments where they'll just speak to the carer, but they won't talk to the patient, as if you're not in the room. So including both people, because you don't take someone with you just for the sake of it. You take them so that they can also remember what the doctor's saying, they can help ask the questions. So those sort of things. I think just listening, and all I can say is going to Scleroderma Clinic, you're not rushed, so that's also important. And I think there should be a time that maybe on your first appointment, you've got another two-way communication with those doctors, that in 3 months or in 6 weeks you can just give a quick phone call or a telehealth consult just to go over those questions that you were asked, that you were concerned about, because it just saves you worrying for the next 12 months or 6 months. And you go to Google and you go, oh gosh, they suggested this drug, what's going to happen? So I just think the more communication the better.
Yes, thank you. Very nicely summarised. So really, I think good multidisciplinary care takes a village of people who are dedicated, who are passionate about what they do, but it also takes time. It's not something that can be rushed, and that's certainly something that we've found, is that there's so much to talk about, so much communication to be had, that you really can't rush it. So on that note, I'm sure that everyone will agree that our panellists are really exceptional people. They're exceptional in so many ways, and we'd like to thank them for being here, for sharing their insights, and for inspiring us. We do have a token of our appreciation for each of you, and...
The best one's for you, Mandy.
Oh, gosh. Wow, that looks lovely. Thank you very much. Oh, it's heavy. Thank you. Thank you very much. It's very kind.